Our topic continues with subacute and chronic headache. Here we'll take a look at pseudotumor cerebri. Who's your patient? Patient comes in with this chronic headache, also called idiopathic intracranial hypertension. In other words, this is your ICH. Now, idiopathic because we don't know exactly as to what causes it. We do know that there's a particular drug that you should be extremely familiar with that might be a possible etiology, and that's your ATRA, L-trans-retinoic acid. But pseudotumor cerebri, as the name implies, pseudo means false, a tumor-like lesion, or should I say a tumor-like manifestation. And by that we mean there's a headache taking place. You'll find papilledema on fundoscopic examination, but absolutely no evidence of a tumor. It described as diffuse, dull, ache, pressure. Remember, this is chronic headache. Onset is gradual, but often progressive. Headache is often worsened by laying down and by physical activity. Blurred vision is common. Horizontal diplopia is occasionally seen. And bilateral cranial nerve 6 abducent palsy can be seen. So this would be a good time to review quickly, please, the functions of your abducent cranial nerve 6. And papilledema is quite prominent. Keep that in mind. What does papilledema mean to you? You do a fundoscopic examination and you find around the optic disc, it looks like sun rays. Very bright, huh? That's your papilledema. Now, with that papilledema, you would think that, oh my goodness, there must be prominent. You're worried about intracranial pressure being increased, and that is not a good thing. So keep that in mind. We'll take a look at epidemiology of pseudotumor cerebri. 75% of your patients will be females. That's where your focus should be. She will be in her reproductive age, between 20 to 40. Vast majority of these females are obese, more common during pregnancy, also seen with steroid therapy, vitamin A toxicity, which I was referring to earlier, your ATRA, all-trans-retinoic acid, and maybe perhaps even tetracycline antibiotics. Why? I have no freaking clue. But make sure you know that these are possible causes or medications that may result as an adverse effect of pseudotumor cerebri. Diagnosis, imaging, initially to rule out a mass lesion, because there is no mass. Lumbar puncture to document opening pressure. Elevated at 250 to 450 millimeters. The water pressure in lateral decubitus. It is important that you know the specifics for opening pressure, please. The CSF should otherwise be normal. Formal visual field testing because of papilledema. Early defect is enlargement of blind spot and slight peripheral field constriction. Remember, there is prominent papilledema in this patient, so early on you would find such defects. Management. Well, here, lumbar puncture to make sure that you figure out what that opening pressure is. Weight loss, carbonic anhydrase inhibitors, Diamox, shunt optic nerve fenestrations. You do want to relieve some of that pressure that's taking place with idiopathic intracranial hypertension, aka pseudotumor cerebri. Summary of pseudotumor cerebri: female, early, young, obese. Preventive medicine: weight loss. Signs and symptoms: blurred vision, headache. The differentials include, if you remember, we talked about venous sinus thrombosis. So during pregnancy, please be very careful, because during pregnancy with estrogen may result in a thrombus formation in the sagittal or the transverse sinus. I even showed you an image where the transverse sinus was absent. That's venous sinus thrombosis. Here we have pseudotumor, mass lesion, migraines as being differentials. Diagnostic: lumbar puncture we talked about earlier, specifically the pressure of 250 to 450 millimeters mercury. Treatment: weight loss, carbonic anhydrase inhibitors, and shunting.